Good evening, everyone. We will be starting oncology from where we left yesterday. Good evening, everyone. Please give the thumbs up if I am audible and visible. Visible. Good evening, Isaac. Is it audible and visible? Should we start? Okay. So yesterday we studied that when a patient came to us in the OPD, and as per clinical feature we suspected and the CA cervix, CA endometrium and ovarian tumor, and then we did the confirmatory test. The confirmatory test for CA cervix is punch biopsy, okay, and the confirmatory test for CA endometrium is endometrial biopsy, and confirmatory test for ovarian tumor is tumor marker and ultrasound, right? That we did yesterday, okay. And then we studied on the slide that how we will interpret these reports, right? CA cervix and CA endometrium, as we have done biopsy, so it is not necessary that only cancers will come. It is possible that their pre-malignant lesions can also come. Like in CA cervix, there come they can come CIN2 or CIN3. There the treatment is LEAP. And if invasive cancer, what is invasive cancer? If dysplasia has penetrated the basement membrane, then it is known as invasive cancer, right? And if squamous cell carcinoma has come, then we will take the CA cervix patient for clinical staging, isn't it? That was what we studied, right? And CA cervix is the only cancer for which we do clinical staging, right? And for CA endometrium, we have taken the endometrial biopsy. So it is possible that pre-malignant lesion can come. Pre-malignant lesion of endometrial biopsy is simple or complex hyperplasia with atypia or without atypia. Of course, simple hyperplasia without atypia has least chances of becoming CA in the future, and its chances are 1%. Those of the students who know this, you can type in the chat box. Simple hyperplasia without atypia, chances are 1% to become cancer in the future. Simple hyperplasia, sorry, complex hyperplasia without atypia, chances are 3%. And simple hyperplasia with atypia, the chances are 8%. And complex hyperplasia with atypia, the chances are 30%, okay. So you can remember it by the one which has the least chances is 1%, and the other three are 3 into 10 equals to 30. 3 into 10 equals to 30, okay. So complex hyperplasia without atypia is 3%. Simple hyperplasia with atypia is 8 or 10%, somewhat near it. And the complex hyperplasia with atypia is 30%. And the without atypia pre-malignant lesions, their treatment is, please write down in the chat box, it has been asked many times, what is the treatment of hyperplasia, simple or complex, any, without atypia? What is the treatment? Yes, Dr. Isaac, Dr. Isra, what is the treatment of simple or complex hyperplasia without atypia, because the chances of CA endometrium is are very less, so they can be treated by progesterone, right? They can be treated by progesterone only. Okay, Isra, I was talking about the treatment. Okay, so the treatment is only progesterone, and if family is complete, even in that cases we will do hysterectomy. Progesterone is reserved only for those cases in which uh, the family is not complete. Okay, so if atypia is there on the endometrial biopsy, the pre-malignant lesion atypia is there on the endometrial biopsy, then the treatment is hysterectomy. Okay, whether the family is complete or not. Okay, 2 3 years before the question was asked on this percentage. These days they are not asking on percentage, but they are asking on the treatment. So you should know that the treatment of pre-malignant lesion without atypia can be progesterone if the family is not completed. If the family is completed, then the treatment is hysterectomy. And but if the lesion is with atypia, whether the family is completed or not, in the both the phases, the treatment is hysterectomy. Okay, questions are more asked to you on pre-malignant lesions, right? Then malignant lesion. Now if on the endometrial biopsy it came out to be adenocarcinoma or endometrial carcinoma, then now we have to treat this cancer. And what will be the treatment of endometrial carcinoma? It will be chemotherapy, radiotherapy, depending on staging. So what if the cancer comes on biopsy? Then we have to do the surgical staging. And what is the surgical staging? It is hysterectomy plus BSO, bilateral salpingo oophorectomy. Okay, the treatment of ovarian humor. Now if the tumor markers have come positive, it means that the ovarian mass which was there in the abdomen with which the patient has come is a tumor. It can be benign or it can be malignant. Only after biopsy we can say that it is benign or malignant. But what we will do if it is a tumor? It has to be removed, right? It has to be undergone biopsy. So the surgery, which is, it means it has to undergo surgical staging. Okay, the surgery which has to be done for ovarian tumor is debulking surgery. Debulking is remove everything which is involved in the growth as much possible. Okay, and we have to send that debulking that tumor mass to biopsy. Okay, and then we have to send 3 more biopsies. One is of ascitic fluid, number 2 is of retroperitoneal lymph node, and number 3 is of omentum. All these 3 are sent if tumor markers have come positive. Okay, so mainly 4 biopsies goes in the patient of ovarian tumor with tumor marker positive. The tumor biopsy, the ascitic fluid. If ascitic fluid is not present, then we send peritoneal washings. Okay, and if ascitic fluid is present, then we send ascitic fluid. Number 3 is retroperitoneal lymph node biopsy, and number 4 is omentum. All this is done because we can't operate again and again. If it comes out to be malignant, then it's not that we will open the we will operate it again. I hope you got it. Now let's go to the another slide. Just take this question. Left side ovarian tumor. You have to be very fast in answering. Okay, today class will be only up till 6 p.m. Okay, left side ovarian tumor and HCG is 4 international unit per ml, and AFP is normal and LDH is raised. What is the diagnosis? A patient come to you with left-sided ovarian tumor. The tumor marker HCG was sent and the tumor marker alpha fetoprotein was sent and LDH was sent. These three tumor markers were sent, but the LDH was raised, HCG was just slight raised. So what is the diagnosis when LDH is raised? Please write down. You can also take guess. It is not exam. Please, if you know it, well and good. If you don't know it, simply the examiner is asking, if the tumor marker LDH is raised, what is the tumor name? What tumor it can be in the abdomen? Yes, answer is A, dysgerminoma. Right? AFP is raised in yolk sac tumor and HCG is raised in non-gestational trophoblastic tumor. Now this is the another question. CIN3 on punch biopsy, what is the treatment? CIN3 on punch biopsy, what is the treatment? Yes, please take this question. Write down, give the answer fast. Very good. Give the answer fast. A patient came with cervical growth on the cervix. We did the punch biopsy and report comes out conization. Isra, it's not conization, it is leap. Conization is done in invasive cancer. Okay? In CIN2 and CIN3, leap is done. Leap is done. Is it okay? So the Isaac, you are right. Uh, uh, Dr. Isaac, you haven't written the answer. That was a previous answer, I think. So the answer is A. You got it, Isra? Let's take the next question. 55 years P3L3 obese hypertensive lady with post-menopausal bleeding. Cervical biopsy NAT. Endobiopsy complex hyperplasia without atypia. Patient has came to you with post-menopausal bleeding. I think camera is coming there. I will move the camera. On two biopsies were taken. Cervical biopsy didn't give any result, and on the endometrial biopsy it was complex hyperplasia without atypia. What is the treatment? Yes, the treatment is hysterectomy. It's very good. As it is without atypia, so here the treatment is hysterectomy because the family is completed. Then why to take the risk? Okay. So let's take the another. So now let's do the most difficult thing, the staging of the cancers. Okay, let's do the most difficult thing, staging of the cancers. As I have already told in my one video that staging is to decide the treatment of the cancers. First we will be doing the CA cervix staging. Okay, so what is CA cervix? CA cervix, how CA cervix spreads? If the cancer is a growth, a growth which can spread to whole body. If it is limited to only that organ, then of course it is then of course it is stage first. What is stage 1? Stage 1 of every cancer, whether it is CS cervix, whether it is endometrium, whether it is ovary, stage 1 of every cancer is limited only up till that organ. Okay, so CS cervix, if limited only up till cervix, is stage 1. Okay, and then next stages depend that how the cancer spread. So this is a very common question: how the cancer spread? CS cervix spread by lymphatic spread. CS cervix has a lymphatic spread. Okay, the another spread which the CS cervix has is hematogenous. All cancers in the last stage 4, they spread by blood. Okay, the initial spread is by lymphatics. Okay, so for to learn the CS cervix staging, I would like to tell you that you have to make a picture in your mind like this. ठीक है, because CS cervix is uh, has to be done clinical staging, so we should know each and every point of the CS cervix. Okay, draw up a picture of uterus and cervix in your mind, and then divide this cervix and uterus into circle. The one which is inner to this circle is stage 2, and the one which is outside this circle is stage 3. Okay, this is a very helpful trick. Even when we are examining the patient in the OPD, we use this trick. Okay, so stage 2 is inner circle spread inside the circle to this, and stage 3 is outside it, and stage 4 is to the whole body, right? Stage 1A is micro lesion. The lesion on the cervix is stage 1 is divided into 1A and 1B, right? Stage 1A is the lesion on the cervix which is not visible by the naked eye. It means it was visible by colposcope. So which lesions are not visible by naked eye? The one which are less than 0.5 mm. One which are less than 0.5 mm. Okay, the one which are more than 0.5 mm are stage 1B. Is it okay to all of you? How you will divide the stage 1 into 1A and 1B depending on the size of the lesion can be seen with naked eye or not with naked eye. No, when the lesion is not seen with naked eye, it means it is a very small lesion. It means it is less than 0.5 mm. 0.5 mm cannot be seen with naked eye. Okay, so it is 1A, and if it is more than 0.5 mm, lesion size is more than 0.5 mm, then it means that it is stage 1B. Okay, stage 2A is upper 2/3 of the vagina. Okay, so here we have divided the vagina into inner circle. This is vagina. So this inner circle one is vagina. I previously told you, sir. I previously told you. I previously told you. Isra, you are asking it is in depth or superficial. Uh, in the new classification, it is in any dimension. Is it okay, Isra? In the new classification, it is in any dimension. Okay? Not only depth, in any dimension. Okay? Okay. Then next is we have divided the vagina into two circles. So stage 2A is in the upper two-third vagina. Stage 2A is upper two-third vagina. ठीक है. And stage 2B is this parametrium, this area which is near the vagina. Okay. 2B, have you got it? Stage 2B is in the parametrium. Stage 3A is lower one-third vagina. This is very favorite of examiner. What is stage 3A? If you were examining the patient and in the lower one-third the lesion is present, then it means it is stage 3A, right? And if you did the PV and you saw that the growth is also going up till pelvic wall, ठीक है, up till pelvic wall, almost here it is pelvic wall, right, up till pelvic wall, then it is 3B, stage 3B. I hope you got it. Stage 2A is stage 2A is in the upper two-third vagina and parametrium, and stage 3A is lower one-third vagina and up till pelvic wall. And what is stage 3C? Stage 3C is para-aortic and pelvic lymph node. Okay, stage 3C is para-aortic and pelvic lymph node. Okay, and stage 4A is bowel and bladder, nearby organs. Okay, bowel and bladder. And 4B is rest body including inguinal node. This inguinal node is very favorite of examiner. As we have studied in basic obstetric, that cervix does not drain into inguinal node. Cervix does not drain into inguinal node. So if the lesion has spread to inguinal lymph node, it means that the lesion has the stage 4 metastasis. Okay, 4B. Now can you tell me what is the lymphatics where the cervix drain? The mnemonic for the lymphatics where the cervix drain is HOPES. H stands for hypogastric lymph node, okay, or internal iliac. O stands for obturator. Obturator is the most common. P stands for parametrial or paracervical or paracervical or parauterine or ureterine. These are one and the other name. And next is E stand for external iliac. This is the sentinel lymph node. First, parametrial was considered sentinel. These days, the external iliac is considered sentinel. So you are going to mark as per the option. And S stands for sacral. Okay. Endometrium staging is not expected in your exam, but still I would like to tell you because it is very similar to the CA cervix. After 3C it is same, right? After 3C it is same. 3C, 4A, 4B is same that of CA cervix. Only we have to learn till 3B. Okay, how this endometrium spread. ठीक है, up till endometrium it is stage 1. Okay, and its spread is direct spread. Direct spread means it will spread organ to organ. Do you know which organs are there? See, this is endometrium. Then there is myometrium and serosa, and here it is cervix, and then it is vagina, right? And here's our fallopian tube and ovary, right? So organ to organ it is spreading. As endometrium is very very fine, very small, so stage 1A is endometrium and less than 50% of myometrium. Stage 1B is more than 50% of the myometrium, right? So from the endometrium it has spread to the myometrium. Stage 1A is endometrium and less than 50% of the myometrium involved, and stage 1B is more than 50% of the myometrium. Stage 2 is involvement of the cervix. After endometrium myometrium we will not go to serosa and fallopian tube, because then peritoneum will be involved and will be a massive spread. Now we will come downwards. Stage 2 is cervix. Stage 2 is cervix. Stage 3A is serosa and adnexa. Stage 3B is vagina. Here also it is most commonly which is asked in exam is vagina. ठीक है. What is the staging if the cancer has spread to vagina? It is 3B, right? It is 3B. Okay. In the CA cervix also they ask what is the staging when lower one third of vagina is involved, when upper two third of vagina, it is 2A or 3A, and in CA endometrium it is 3B. Please don't mark 3A. I have done this question wrong in exam. I have put there 3A CA endometrium. It is 3B. In CA cervix it is 2A and 3A. Okay. And rest 3C, 4A and 4B is similar to the CA endometrium. Okay. CA ovary has the coelomic spread. Coelomic, what we mean by coelomic? Coelomic means cavity to cavity. So here I would like to tell you, you just need to learn the cavity spread. Stage 1 is limited to ovary. If the lesion is limited to one ovary, it is 1A. If the lesion is involving both the ovaries, it is 1B. Okay. Stage 2 is when pelvic cavity is involved. Here I would like to tell you that pelvic cavity contains bowel and bladder, right? So if uterus, adnexa, bowel, bladder, they are involved, then it is stage 2. Stage 2 means it is a healthy stage. It can be easily it is treatable, right? So if in the CA ovary they ask you that bowel, bladder or uterus, adnexa is involved, what is its stage? Then you have to say it is stage 2. Stage 3 is abdomen and abdominal cavity, and stage 4 is metastasis. So it is all, you have to divide the whole peritoneal cavity into two cavities, pelvic cavity and abdominal cavity. Okay. Yes. Please take this question. Endometrial cancer with vaginal metastasis. Staging is. Please take it fast. We have done it now itself. Yes, its answer is 3B, and in the CA cervix it is 2A or 3A. Okay. So next is lymphatic spread of CA cervix, that we have done, right? Okay. Now let's learn the treatment of cancers. Now what are the cancers treatment? So CA cervix, the treatment is radiotherapy in all the stages. In all the stages it is radiotherapy. Okay. but we never prefer radiotherapy if other treatment is available. If any other treatment, okay, all the cancers, they have three treatment: surgery, chemotherapy and radiotherapy. We have usually to choose among this. Okay, we have to choose a treatment. Either the treatment will be surgery, either the treatment will be chemotherapy, or it will be radiotherapy. We have to choose among this. Okay, the treatment of CA cervix in all the stages, it is radiotherapy. Okay, but we don't prefer radiotherapy as the treatment. If other treatment is available, we prefer the other treatment. Why it is so? Because radiotherapy has many side effects, okay. सो वी प्रेफर कि रेडियोथेरेपी ना ही देना पड़े, ठीक है. बेटर टू अवॉइड रेडियोथेरेपी इफ एनी अदर ट्रीटमेंट कैन correct the problem. Okay, so one thing is this, and another thing which you have to remember is that in CS cervix only radiotherapy has not good treat is not good. Chemoradiation is good. What is chemoradiation? That before the radiotherapy, if we give a chemical agent, especially if it is platin based, usually we give cisplatin. Okay, then the sensitivity of the body to that radiations increases and cancer heals very fast. Okay, are you getting it? So you are never going to ask in the options chemoradiation is also given and radiotherapy is also given. You will always mark chemoradiation because the cancer heals very easily if the chemoradiation is given. Chemoradiation means giving cisplatin before the radiotherapy. Okay, only cisplatin will not cure. So in the options, usually they give chemoradiation and radiotherapy. So the answer you will mark is chemoradiation. Okay. Okay. Next is that surgery can also heal CA cervix. Okay, surgery can also heal CA cervix, but only up till 2A stage. That is why I have written here 2A. Okay, surgery can also heal CA cervix only up till 2A. So you have to remember 2A term. For CA endometrium and CA ovary, you have to remember 1A. Okay, surgery can treat CA cervix up till 2A. CA endometrium में surgery is sufficient up till 1A, and in CA ovary surgery is sufficient up till 1A. Will you remember? For CA cervix it is 2A, for CA endometrium it is 1A, and CA ovary it is 1A. Okay, CA cervix. So which surgery is done in CA cervix? Can you tell me? If the family is complete, then we do hysterectomy. If the family is not complete, then we do conization or trachelectomy. Okay, after 2A, we will give chemoradiations. Okay, is it clear to you? I hope it is clear. CA endometrium is as for CA endometrium, we have done surgical staging. So already we have done the surgery. So it is quite commonly asked in exam what you will do if on a biopsy report it come out to be CA endometrium stage 1A. What was 1A? less than half of the myometrium is involved, right? So we will do nothing because already we have done surgery. Surgical staging was done, right? So stage 1A, no treatment required. After stage uh, 1A, that is from 1B to stage 2, there the treatment is radiotherapy. Radiotherapy. So what is the treatment of CA endometrium after 1A? It is after 1A the treatment is radiotherapy. In the CA cervix it was chemo radiation. ठीक है? And in the CA ovary the treatment after 1A is chemotherapy. Chemotherapy. Okay, all the CA ovaries are resistant to radiotherapy except dysgerminoma. Except dysgerminoma. I hope it is clear to you, all of you now. Okay, treatments are clear. Please take this question and we will then wind up oncology and start basic obstetrics. Endometrial cancer stage 1B. Write down very fast. Please write down fast answer. It's endometrial cancer. Write down fast. What is the treatment in endometrial cancer? Yes, it is radiotherapy. Take the next question. Ovarian malignancy, all is done except debulking. We had done the debulking in the surgery, right? IV chemotherapy, intraperitoneal radiotherapy. What is in the ovarian malignancy? All is done except D. Radiotherapy. Very good, Isra. 55 years lady with CA cervix stage 3A. This is favorite question of examiner. This is favorite question of examiner. Please take it. Stage is 3A. Isra, you have written D, right? Better no. After 2A, surgery cannot treat the patient. After 2A, chemotherapy plus brachytherapy. So answer is C. Have you got it? Zabi Kausar, please. It is stage 3A. I told you for CA cervix, you have to remember. Yes, Pankil, you are right. It for CA cervix, surgery is sufficient up till 2A. For CA endometrium, surgery is sufficient up till 1A. For CA ovary, surgery is sufficient up till 1A. After After 2A, what is the treatment of CA cervix? It is chemo plus chemo radiation, right? Beta, chemotherapy, CT is chemotherapy plus brachytherapy. Brachytherapy is a type of radiotherapy. Isra, you got it? CA endometrium is radiotherapy up till stage 2 and ovary is chemotherapy. Have you got it, Isra? CT is for chemotherapy plus brachytherapy means a type of it. That is why I always say attempt more and more question. If you will able to attempt, then you will know the terms this. Okay? So now let's start with basic obstetrics. Okay? So we will be doing the obstetrics very fast because from the basic obstetric very less is expected. Okay? First question in the basic obstetrics is how to calculate the EDD. Okay, how to calculate the EDD. So if the menstrual cycle is regular and 28 days, then we will calculate the EDD by Naegeli's formula. And what is the Naegeli's formula? That in the LMP we will add 9 months and 7 days. The EDD will come. Okay, here I would like to tell you, in the November exam they have specifically asked first day of the LMP or last day of the LMP, right? So the answer is first day of the LMP. Okay, if the menstrual cycle is regular and of 28 days, in this condition, we will calculate the EDD by Naegeli's formula, and Naegeli's formula is in the LMP add 9 months and 7 days. And in the last November exam, this INSET exam, they specifically asked in first day or the last day. The answer was first day. Okay, if the periods are irregular or if there is contraception failure, then we are not going to calculate the EDD by Naegeli's formula. Then we will use the ultrasound, because in both, if the periods are irregular and if it is a contraception failure case, in both the cases we don't know, right, when ovulation has occurred. So we will use Naegeli's formula only if we know when the ovulation is there. If the periods are irregular and contraception failure is there, in both the cases we don't know when the ovulation has occurred. So we will use the ultrasound parameters. If the patient has come to us in the first trimester, then the parameter of the ultrasound which we use is CRL, crown rump length. If the patient has come us to in the second trimester, then the ultrasound parameter which we use is BPD, biparietal diameter. If the patient has come to us in the third trimester for the first time, the parameter which we use is femur length. Okay, question has asked on all these three, and the question it was asked in NEET PG 2021 that a patient was taking oral contraceptive pill, the patient conceived. You will calculate the EDD by Naegeli's formula or by ultrasound CRL or by per abdomen or by any other method. So the answer was by CRL. Why we don't calculate it Naegeli's formula? Because Naegeli's formula is reserved only for the cases where we know that when the ovulation is occurring. Okay, and out of all these three parameters, the most accurate EDD which has only 1 or 2 day disparity, okay, is the CRL. first trimester EDD calculated by CRL. Question has been asked on this point also. Okay, so these are some basic obstetric things and question has been asked. Very simple, no hard concepts. Okay, so out of all these three, the best parameter is of the first trimester parameter, that is CRL. Now let us talk about the signs of pregnancy. The early signs of early pregnancy are the first trimester, 6 to 8, the signs which come in 6 to 8 week. This is favorite of examiner because obstetrician does not want ki you come to know about pregnancy after doing UPT test. Okay, so every teacher wants ki bina UPT test ke hi, without doing UPT you should know that a patient is pregnant or not. Okay, okay, do you got it? Right. So first is the uterus and cervix, they become soft. Okay, uterus and cervix, they become soft. Okay, why they become soft? Because there is lot of water retention. Okay, when uterus gets pregnant, conceive, they become, uterus becomes soft, cervix becomes soft. The softening of cervix is known as Goodale sign, and softening of isthmus is known as Hagar sign. Please don't mix both. Okay, how you will remember the mnemonic for that softening signs are known as Goodale and Hagar. Okay, a mnemonic for that is, okay, that if one has to pass good stools, the stools has to be soft. Okay, so good stands for Goodale, stools stand for Hagna. To differentiate in Hindi it is known as Hagna. Okay, and softening, soft. To pass good stools has to be soft. So that is the mnemonic. Goodale is cervix and Hagar is isthmus. Hagar is softening of isthmus. How the isthmus is softening of isthmus is checked? Cervix we just check by touching the cervix. Okay, it is hard or soft. Isthmus is checked by bimanually examining. By one hand in the posterior fornix and one hand in the anterior fornix. You can see here the examiner is examining bimanual. One hand on the abdomen and one hand in the cervix, posterior fornix. And if the at the isthmus, if you can feel both the hands, then it means that the isthmus is soft. Okay, both the fingers, if you can feel like this, it means that feel both the fingers, it means isthmus is soft. That is why you are feeling both the fingers of your hand. Okay, the another is bluish Zabi Kausar. I don't know what you are want to say by saying 6 weeks. Okay, that this sign comes at 6 weeks, it is right. If you want to say this, that this sign comes at 6 weeks, it is right. Okay, now the bluishness, the whole the uterus, cervix and vagina, it gets blue. Why it gets blue? Because there is increased blood flow in the reproductive tract. In the whole body there is increased blood flow in the pregnancy. Especially the increased blood flow is in the genital tract, reproductive tract. That is why there is a bluish tinge in the genital tract. The bluish tinge in the cervix is known as Chadwick. C for Chadwick, C for color. Okay, And next is the bluish tinge in the vaginal wall is known as jacquemer. Jacquemer, how you will remember jacquemer? Jatak. Yes, yes, it's right. Yes, it's right, Mohit. Mohit Rohela, it is right that sign comes at 6 to 10 weeks Hagar. Yes. Jacquemer, Jacquemer is how you will remember that Jacquemer is bluish sign of the vagina. You will remember it by Jatak. What is the meaning of the word Jatak? Jatak means bright color, bright colors, right? So J for bright Jatak and J for bluish color vagina. And because of the increased blood flow, one can feel the uterine artery pulsation in the lateral fornix, right? One can feel the uterine artery pulsation in the lateral fornix, and that is known as osciender. Osciender, ठीक है? दिल के अंदर, दिल के अंदर, सो इन द हार्ट, दिल के अंदर, ठीक है? दैट इज धड़कन, पल्सेशन, पल्सेशन ऑफ द यूट्राइन आर्टरी इज फेल्ट. ओके. ब्लीडिंग, when placentation occur, then spotting occurs. If the spotting is occurring on the day of the LMP, then it is known as placental sign, right? When I was giving my exam, this question came, what is placental sign? And in the option it was not given early signs of pregnancy, it was given placental sign is spotting, just all. Placental sign is spotting, yes, that's all. Okay, so placental sign is pregnancy spotting or nothing like that. Okay, so it can come. What is the placental sign? Placental sign is bleeding on the day of the LMP. Okay, and otherwise the bleeding occurred, then that sign is Hartmann. Okay, Hartmann, right? Right now the uterus is in the uterus, implantation occurs only on one side, so the uterus get laterally deviated and soften on the implantation sign, right? So this sign is known as Piscac sign. Piscac sign, as if someone has kicked the uterus. Because implantation occurs only on one side, so uterus gets laterally deviated and becomes softer on that side, and it is due to implantation. It is known as Piscac sign. Okay. Because fetus is a foreign body. Because fetus is a foreign body, so in response to that foreign body, continuous contractions occurs in the uterus to expel that foreign body. These contractions can be felt, and the sign is known as Palmer sign. What we do in Palmer sign, we hold the uterus bimanually. We hold the uterus bimanually and we feel the contractions. After the early pregnancy, it becomes Braxton Hicks contractions. Okay. So I hope all the signs are clear, right? Late signs, out of this, the color sign Chadwick and Jacquemer, and the softening sign Hagar and Goodale. These are very favorite of examiner. Once again, I would like to tell you, the favorite of examiner is these two, Goodale, Hagar, Chadwick and Jacquemer, right? These are the favorite. Now let us see the late signs of pregnancies, the sign which come in second, third trimester. Okay, what are those signs which come in the late trimester, second or third trimester? They are the internal ballotment. Okay, in what is internal ballotment? You push something, again if you feel a force, that is known as ballotment. If you push the cervix by internal examination and again you feel the force, that is known as internal ballotment, and it is seen at 16 to 28 weeks. It is seen at 16 to 28 weeks. Are you getting my point? Okay. When the internal allotment is seen at 16 to 28 weeks. Why it is so? Because this is the time when sufficient amniotic fluid is there, that if you give a push, then the amniotic fluid will revert back to you. Okay, internal ballotment comes at 16 week. The next is the quickening sign. Quickening is feeling of the fetal movements by the mother. It comes at 18 weeks in primary. It comes at 18 weeks in primary. Why it is so? Because now first we were doing the examination internally and then feeling it. Okay, then feeling the water displacement or ballotment. Now here the mother is not doing internal examination, so bit later, 2 weeks later, 18 weeks. External ballotment is feeling of the amniotic fluid, just doing like this, and again the pressure diverted to this hand. So that is seen at 20 weeks. External ballotment is felt at 20 weeks after a gap of 2 weeks. Okay. Lightning is seen at 38 weeks. Lightning, what is lightning? Lightning is seen at 38 weeks. What is lightning? That at around 37 weeks, the head engages. It goes inside the pelvis. Then mother feels light because fundal height gets reduces, and that lightning is seen at 38 weeks. I hope it is clear to you now. Internal ballotment at 16, quickening at 18, external ballotment at 20, and lightning at 38 weeks. Now let us see that how the fundal height tell us the period of gestation. If the fundus height is only up till pubic symphysis, up till here, if the fundal height of the pregnant uterus is only up till the pubic symphysis, then it is 12 week. Okay, if it is up till fundal height is up till umbilicus, then it is 24 weeks. And if it is up till xiphisternum, then it is 36 weeks. It is just a table of 12. 12, 24, 36. Okay. For late science, it was 16, 18, 20. A 2 week gap. And for the fundal height, it is a table of 12. 12, 24, 36. This umbilicus is very favorite of examiner. They keep on asking. When the fundal height is at umbilicus, what is the period of gestation? It is 24 weeks. Okay, now this is the images which can come in your exam. What does this first image indicates? This is which sign? Please write down in the chat box. Please write down in the chat box. In the first image, which sign is being elicited? Write down of second image also. I am giving the number to every image. Third, fourth, 5. Yes, Isra, you are right. First image is Hagar sign. Please write down the sign name and image number. Image questions give you large confidence. I know that. Please write down what is the second image is telling. Please, all of you are watching. It's not an exam. You can have plain guesses. You can guess it too. Chadwick. Second is Chadwick. Yes, you are right. Third is Osiander. No, dear Isra, third is Pisquack. See, they are examining it literally. Third one is Pisquack. Okay. Fourth one is internal ballotment. And fifth one is Isra. Fifth one is external ballotment. Okay. It is right. Fourth one is internal ballotment and fifth one. Yes, Jabi, you are right. Second is Chadwick. Vaginal wall is also seen. Even if you write there Jacquemer, it is also right. Okay. Okay. Isra, have you got? Third one is not Osiander. Third one is Piscac. Piscac sign. Third one is not Osiander. Third one is Piscac because literally it is palpating. Are you able to get this thing, Isra? Zabi, are you able to? Okay. Okay. So now let us see the different events on which day. So these are the events which are very commonly asked. Okay. What is morula? Zygote is a one cell stage, right? Zygote divides into two cell, then into three cell, then into from one cell zygote it divides into two, then it becomes four cell, then it becomes 8 cell, then it becomes 16 cell. Okay. Okay. So morula is a 16 cell stage. Okay. Morula from taking the fertilization day as 0 day, it becomes morula on 4th day. When is morula there in the human body or in the female body? On the 4th day. On the 4th day. Now all these days are after fertilization. Okay, I have written here all these days are after fertilization, and that is how they are asked in exam. So you are not going to write there as per LMP. Only these things are asked after fertilization. Okay, only these things are asked after fertilization. Rest all things in the obstetrics and gynecology are asked as per LMP. Okay. Okay. So morula is the stage when the when the embryo enters into the uterus. Okay, when the embryo enters into the uterus. So when the embryo enters into the uterus at the morula stage on the 4th day. Have you got this? No one will do wrong in the exam. It is highly expected question. When, at what day of the fertilization the uterus enters into the embryo enters into the uterus. Fertilization occurs in the ampulla. Fertilization occurs in the ampulla. At what stage the embryo enters into the uterus? At 4th day, at morula stage. Okay. The blastocyst is formed at 6th to 9th stage. The blastocyst is formed at 6th to 9th day, and that is when the implantation occurs. Implantation occurs at which stage? Implantation occurs at blastocyst stage and at 6th to 9th day. Very common question asked. Okay. These days one liners are asked in INSET, one liners are asked in NEET PG. One liners are asked in FMG exam. So you all will focus on these basic things. No difficult concepts. At the blastocyst stage, the implantation occurs at 6 to 9 day. Okay, uteroplacental circulation is established at 11th day after fertilization. And fetoplacental circulation. What is fetoplacental circulation? Formation of primary villi, secondary villi, tertiary villi. It is established at 21 day. Okay, so here you can remember 4, 8, and this is 11 and 21. Uteroplacental circulation is established at 11th day. Uterus and placenta circulation is established at 11th day. The fetoplacental circulation, or in other words they can ask formation of primary, secondary and tertiary villi, is completed by 21 day. Okay, because three type primary, secondary, tertiary villi are forming, they will take time, right? They will take time. When we say a structure embryo from the starting of third week, it from the starting of third week up till 8th week. What is the definition of embryo? From the starting of third week up till the 8th week is embryo. Okay, and what is fetus? From the beginning of the 9 weeks up till delivery, right? And newborn or infant is after delivery. I hope you got it. I hope you got this. Okay, let us take the another let us go on the next topic, placenta. Okay, so this was the question which was asked in the last FMG exam. What is the type of placenta human beings have? The placenta is hemochorial. What do you understand by hemochorial? Please, what do you understand by hemochorial? Hemochorial means the chorions are in the blood. The chorions of the chorionic villi are in direct touch with the blood. And as you all know, we have read in preeclampsia that extravillous trophoblast removes the tunica media of the spiral arteries. Isn't it? We read now, right? So that is why, because tunica media is removed, so this chorionic villi are in direct touch with the blood. Okay, Isra, don't know what fact you don't know, tell me. Okay, placenta, human placenta is hemochorial. Mohit, ma'am, fertilization occurs if in option ampulla isthmus junction, can it be marked? No, fertilization occurs only at ampulla. If in the options ampulla is not there, then you can mark ampulla isthmus junction. But I am telling you specifically, the fertilization occurs only in the ampulla. Ampulla has very soft mucosal folds, large mucosal fold. That is why it is a bed of fertilization. Okay, if ampulla is not in the option, then you will mark ampulla isthmic junction. Okay, okay. Now the implantation in the human beings is, last time it was asked what type of placenta human beings have. Answer was hemochorial. Now they ask you what, now they can ask you what type of implantation human beings have. So human beings have interstitial implantation. What do you mean by the word interstitial implantation? Interstitial implantation means that the blastocyst comes and dig inside the endometrium, right? The, see, you, I have shown here in the diagram that this red one is, this red color is endometrium. Okay, This red one is endometrium, and this purple one is myometrium and serosa. Okay. So what is interstitial? Interstitial is means that the blastocyst come and dig inside the endometrium. उसने अंदर ड्रिल मतलब डिग करके अंदर गया. ओके, it has dig in the endometrium. So the decidua which is below is known as decidua basalis. Okay, so here comes the term decidua basalis is the decidua which is below this implanted blastocyst. Decidua capsularis is the decidua which is above the blastocyst, and rest of the decidua is known as decidua parietalis. Okay, parietalis. Once again, the decidua, as I told you, it is the interstitial implantation, and so it dig inside the endometrium. So the decidua which is below the blastocyst is decidua basalis, and the decidua which is above the blastocyst is capsularis, and the rest of the decidua is decidua parietalis. Is the decidua parietalis. I hope it is clear to you. Okay. Let me show you in the diagram. Okay, this is the, please appreciate, this is the decidua basalis, the decidua which is below the endometrium. Okay, and this is the decidua capsularis, the decidua which is above the endometrium, and this rest of the decidua is decidua capsularis. Okay, this is what if on ultrasound we see this implantation, then it is known as double decidual sac sign. Okay, one sac is formed by the decidua parietalis, and the another sac is formed by the decidua capsularis. Are you getting this thing? Yes, Dr. Isaac, you are right. It is double decidual sac sign. In the diagram you can see. So question can be asked, in the double decidual sac sign, the sacs are formed by, so what will be your answer? Write down in the chat box. In the double decidual sac sign seen on the ultrasound, who are forming the two sacs? Double sac is formed by which decidua? Write down in the chat box. Dr. Isaac, write down the answer. Dr. Isra, Dr. Mohit Ruhela, Dr. Jabi, please write down. Yes, it is right that it is formed by alive fetus, but which part of the decidua are forming the double decidual sac sign? Which decidua, which part of the decidua are forming? Now only I explained. Out of the three decidua, yes, Dr. Isaac, it is right. Decidua basalis and decidua capsularis. Very good. Is it clear to rest all of you? Yes, you are right, Isra. You have written specifically outer by decidua parietalis and inner by capsularis. It can be asked. Okay. So now let us take the another thing. Placenta is formed by chorion frondosum and decidua basalis. So the maternal part which is forming the placenta is decidua basalis, and The fetal part is chorion frondosum. The chorion sac. You all know that. Yes, yes, Dr. Zabi Kausar. It is Decidia capsularis and Decidia paritalis, as there are two sacs. Okay. Yes. Uh, yes, Dr. Mohit, the placenta is formed by Decidua basalis is and Decidia basalis is the maternal part. And as you know that fetus has two membranes, chorion from chorion and amnion. So the chorion has two parts, chorion levi and chorion frondosum. So chorion frondosum makes the placenta, and the other chorion, it makes the chorionic villi. Okay, so who is forming the placenta? Fetal part is chorion frondosum, right? These are very basic things. Question can come. Already in the INS set question has come. Okay, so fetal part is chorion frondosum and the mother part is Decidia basalis, that is forming the placenta. Okay, the weight of the placenta is 500 gram. Its diameter is 20 centimeter and its thickness is 2.5 centimeter, as it was asked in the November INS set exam, so I have included it. Okay. Okay, the fetal part or the part to which the umbilical cord is attached is known as chorionic plate. Okay, the fetal side of the placenta is the part at where umbilical cord is attached, and it is also known as fetal plate or chorionic plate. The part which is toward the uterus or which is attached to decidua is known as maternal plate, basal plate or decidual plate. Okay, okay. And in the placenta there are two type of trophoblastic cells, cytotrophoblast and syncytiotrophoblasts. The syncytiotrophoblasts are the hormone factory. Okay, each and every hormone of the placenta is made by syncytiotrophoblasts, whether it is HCG, whether it is HCG, whether it is HCG, whether it is HPL, whether it is estrogen, whether it is progesterone. So the syncytiotrophoblasts is the hormone factory. Okay, now let us see the other ultrasound signs. After discussing about little bit about placenta, let us discuss the ultrasound signs. First ultrasound sign which come on the ultrasound, first sign which come on the ultrasound is gestational sac. Okay, and it is seen at from 4 to 5 week. Okay, from 4 to 5 week, and the at 5 week the another sign which come is yolk sac. Okay, and from 5 to 6 week it comes the cardiac activity. Easy. From 4 to 5 weeks comes the gestational sac. From 5 week to 6 weeks comes the yolk sac. And sorry, at 5 weeks comes the yolk sac, and from 5 weeks to 6 weeks comes the cardiac activity of the fetus. Okay, and all these signs are seen on TVS. If they ask you, usually they ask on TVS, if they ask you per abdomen, you have to add 1 week more. For per abdomen, you have to add 1 week more. Okay. The intradecidual sign. What is intradecidual sign? The intradecidual sign means the gestational sac, and it is seen at 4 week to 5 week on TVS. Double decidual sac sign, we have discussed it a lot. Double bleb sign is the amniotic sac and the yolk sac. amniotic sac and the yolk sac. Okay. No, yolk sac is Isra, it is not fetal pole, right? Yolk sac is not fetal pole. Or fetal pole is something fetal part. Yolk sac is a sac which gives nutrition to the early fetus. Okay, yolk sac, it gives nutrition to the early fetus. Clear? In this diagram we will discuss it. Okay, so uh, this is the which is this sign on the first ultrasound, and on the second ultrasound which is this sign. Isra, I will take your query little bit later. Please write down in the chat box what does the first ultrasound is showing, which sign. What is this? What is this black black? In the uterus, what is this black black? Which sign is this? Dr. Sack, you are telling double decidual. I'm not asking. I'm asking what is this black black? There are two signs shown in this first sound. I'm just asking what is this black black, the black bubble. No, here we are getting wrong. This is just gestational sac, intradecidual sign. Okay, this black black is, yeah, I'm not asking, Dr. Isra, I'm not asking about the second picture. The first picture I'm asking. In the first picture, double decidual sign is also there. But this black picture is, this black thing is gestational sac. Are you able to understand, Dr. Isaac? In the first picture, right in the center of the uterus, there is gestational sac. It is intradecidual sign. Are you able to get it? Please write down in the chat box. Otherwise, I will explain it more. I was asking in the first picture, what is this black which I have circled. Okay, Dr. Isaac, Dr. Isra, you have got it. That this is gestational sac. And what is this gestational sac known as? It is known as intradecidual sign. Okay, intradecidual sign. And this is the double bleb sign. You all were right. The white, this is the yolk sac. This is the yolk sac. Okay. Yes, Dr. Mohit, thank you. And this is the amniotic sac. Have you got it? Dr. Isra, Dr. Isaac, Dr. Zabi, Dr. Mohit, in the second picture, the above one is the yolk sac and the below is the amniotic sac. Have you got it? Have you got it, Isra? Yes, you're right. And Isra, see carefully. Within the amniotic sac, there is a structure that is embryo or fetal pole. Isra, is your query clear? Within the amniotic sac, I am coloring it. There is a small white structure, and that white structure is fetal pole or embryo or CRL. Is it clear to you, Dr. Isra? Your query is clear. Yolk sac is different thing, and fetal pole is the embryo, or you can say the fetus, first fetus part visible on scan. Okay? If it's how we differentiate between a yolk sac and amniotic sac. See, yolk sac is empty. Yolk sac is empty. Yolk sac is empty and amniotic sac contains fetus. Okay? Isra, is it clear to you? You can see here in the diagram, yolk sac is empty. Yes, amniotic sac always contains fetal pole. Then this fetal pole becomes the embryo. Then it becomes the whole big fetus. Okay, yolk sac contains fluid which gives nutrition. Okay. Yes, Dr. Mohit, you are right. Isra, is the query solved? Okay. Keep on asking the queries. I admire a lot. Nothing should be left in your mind. Okay? Everything should be clear. Now, how many ultrasounds are done in the pregnancy? How many ultrasounds are done in the pregnancy? The first ultrasound is done at 6 weeks, around 6 to 7 weeks. Then that is known as the dating scan or the EDD calculating scan, and that is the first trimester. Okay. The another ultrasound done is the anti-NB scan, that is knuckle translucency nasal bone on scan, and it is done at 11 to 13 weeks. Right? You all know if knuckle translucency is increased and nasal bone is absent, then it tells us about the presence of anomalies. Right? So knuckle translucency and nasal bone scan is done at 11 to 13 weeks. Very commonly asked question. Okay. Then the deep anomaly scan, the big anomaly scan is done at the main anomaly scan is done at 18 to 22 weeks. Are you able to appreciate the first anomaly scan known as anti-NB scan is done at 11 to 13? Yes, Dr. Zabi, you are right. It is done at 11 to 13 weeks. Yes. And the main anomaly scan is done at 18 to 20 weeks. Okay. And Doppler scan or for the placental localization or the growth scan is done at 32 to 32 weeks. 32 to 32 weeks. Okay. The Doppler scan in a normal pregnancy, if not indicated otherwise, is done at 32 weeks. Okay. If the knuckle translucency is increased, then these all are the only screening test. These all are only screening test. If it is increased, then we confirm it by chorionic villi sampling. Chorionic villi sampling. If in the anti-NB scan we get a suspicion, then we do the chorionic villi sampling to confirm it. Right? And the double marker is also done at this time. Beta HCG and PAPE. Right? This is also done at 11 to 13 weeks. So what are the tests which are done at 11 to 13 weeks? Please write down in the chat box. Anti-NB scan, screening test, chorionic villi sampling, and the double marker. Okay, and the double marker. Write down in the chat box that these are the things which are done on 11 to 13 weeks. Okay, the second anomaly scan is done at 18 to 20 weeks. ठीक है, quite commonly asked question. If on the screening we detect any anomaly, then it is confirmed by amniocentesis, which is done after 15 weeks. Which is done after 15 weeks. The triple scan is the triple marker test or the quadruple double marker is the biochem. Two markers tested at 11 to 13 weeks to rule out the anomalies, and the markers are beta HCG and PAP-A. Okay, okay. It is also a screening test for Down syndrome. Triple marker contains 3 biochemical markers and quadruple markers contains 4 biochemical markers, and it is done at yes, and it is done at 16 to 18 weeks. Is it clear? Is it clear? You will not forget this weeks now. I have all put it together. Okay, let us go at the another question. Minimal ANC visits. As per WHO, minimal ANC visit as per WHO is 8. If 8 is not in the option, please mark 4. But first preference is 8. This question has been asked twice or thrice in your exam. And once when it was asked in the exam, 8 was not in option, then you will mark 4. Because there is a term focused ANC by WHO, and if they ask minimal ANC visit as per Indian government guidelines, it is also 4. It is also 4. Okay, but first preference for the WHO question is always, yes, is always 8. Okay. Now let us do the hematological system. What are the physiological changes in the hematological system of a pregnant female? This is the second last slide. Okay, then we will be after this we will be doing the CVS changes, and then we will be ending the class. Hematological system. What are the changes, physiological changes in the pregnancy in the hematological system? Hemodilution occurs. Beta triple test and ultrasound, these are screening tests. It needs to be confirmed by amniocentesis. Amniocentesis and CVS test. Dr. Mohit is asking if triple test confirmed, next management MTP, no. Triple test and this ultrasound, these are screening tests. Confirmative tests are amniocentesis and chorionic villi sampling, where we do karyotyping. Is it clear, Dr. Mohit? Is it clear to you, Dr. Mohit? Karyotype. Dr. Isaac is asking, ma'am, in question, if amniocentesis or karyotype is given, what to choose? Beta karyotype, because after taking the amniotic fluid, we have to do karyotype. Dr. Isaac, is it clear? Okay. Hematological system. What are the changes in the hematological system in the pregnancy? There occurs hemodilution. What do you mean by hemodilution? As you all know that blood is made up of RBCs and plasma, isn't it? So the plasma increases much more than the RBCs. Okay, increase in the plasma is 40% and increase in the RBC is only 20%. Okay, just as we make a kheer in our home, if we increase the milk and we don't and we only increase rice, okay, some material they are saying amniocentesis and some material karyotype was okay. Okay, Dr. Isaac, if it's clear to you, then there is hemodilution because increase in the plasma is more. Okay, when we were studying in 2012, we our seniors told you that just learn hemodilution. Your every each and every MCQ will clear. So this hemodilution word is that important. Okay, and what is hemodilution? Means blood का पतला हो जाना, thinning of the blood. Okay, and why it is so? Because the increase in the RBC is 20% and increase in the plasma is only 40% increase. Okay, increase HB mass because RBC has increased, so the whole HB mass has increased. Okay, so the whole HB mass, hemoglobin mass will increase, but because of hemodilution, the HB concentration, because of hemodilution, HB concentration, it falls. What do you understand by HB concentration? That is what the routine HB we get it done. And blood present in 100 ml. HB, what is HB concentration? HB per 100 ml. Okay, HB per 100 ml. That is what we say कि आपका HB क्या, what is your HB? That is we are asking HB concentration. So HB concentration decreases. Hematocrit also decreases in pregnancy. What is hematocrit? Hematocrit is RBC volume upon packed cell volume. Hematocrit is RBC volume upon packed cell volume. Okay, because RBC volume increases only slight, but packed cell volume increases much more. So hematocrit also decreases. Okay, so hematocrit also decreases. So I hope you understand, right? I hope you understand that HB mass increases, HB concentration decreases, hematocrit decreases. What is the definition of anemia in pregnancy? HB less than 11 is the definition of anemia in pregnancy because there is hemodilution. Due to hemodilution there is increased reticulocyte count, increased reticulocyte is there due to hemodilution. Okay, WBCs also increase normally in pregnancy and platelets decrease. Okay, this is very important finding. WBCs increase in pregnancy and platelet decrease. Pregnancy is a hypercoagulable stage because all the clotting factors increase in pregnancy except two factors. Please write down in the chat box which are the clotting factors which decrease in pregnancy. Please write down in the chat box. Even after seeing the slide you can write down. This is very important. Free के marks हैं ये आपके एग्जाम में. Which are the clotting factors which decrease in pregnancy? Please write down. Please write down. Yes, it is 11 and 13. It is a very frequent asked question. And as fibrinogen increases in pregnancy, that is why the ESR fibrinogen factor also increase. That is why ESR increases in pregnancy. If you will get the pregnant patient ESR done, then its ESR will be 50, around 50. Normal ESR is around 8. Okay, but the pregnant patient ESR is around 50. Okay, because there is increase in fibrinogen. So which factor is responsible for increased ESR? Fibrinogen clotting factor. Total protein in the pregnancy increases. Total protein in the pregnancy increases, but because of the hemodilution, the protein concentration decreases. Okay, total protein in the pregnancy increases, but due to hemodilution, the protein concentration decreases. Okay, same like HB. HB mass increases, but HB concentration decreases due to hemodilution. There are mainly two proteins in the body, albumin and globulin. In a normal human being, albumin is much more than the globulin, but in pregnancy, globulin increases. But in pregnancy, the globulin increases. गोबलू 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 होते हैं ना बच्चे, स्वीट स्वीट गोल गोल होते हैं ना बच्चे. सो इन द प्रेगनेंसी ग्लोबुलिन इंक्रीजेस एंड एल्ब्यूमिन डिक्रीजेस. सो एल्ब्यूमिन ग्लोबुलिन रेशियो इज 1:1. Albumin globulin ratio is 1:1. Let us study the CVS changes. What are the changes in the cardiovascular system? Yes, Dr. Mohit, albumin decrease and globulin increase. And albumin globulin ratio in pregnancy is 1:1. The cardiovascular system changes in the pregnancy is hemodilution. You know, it occurs in the hematological system. Now, all this increased plasma volume has to be pumped by the heart. So this formula of increased cardiac output is equals to heart rate into stroke volume. All these three things increases. Yes, all these three things increases because there is increase in the plasma volume. So heart cardiac output will increase, heart rate will increase, and stroke volume will also increase. Okay, so all the three parameters of this formula increase. Okay, the central venous pressure or the jugular venous pressure remains constant. If it is increasing, it means that the patient is having heart diseases. This is very important thing. It is very important thing. Okay, if central venous pressure or jugular venous pressure increases, it means that it is the heart patient is having heart diseases. Only by this factor we determine in OPD that patient is a normal pregnant patient or heart diseases patient. That is why it has been asked twice or thrice in your exam. Okay. Peripheral vascular resistance. Favorite question of the examiner. Favorite question of the examiner. Peripheral vascular resistance decreases. Why it decreases? Because we studied that there is hemodilution, increase in the plasma volume. Now where this increase in plasma volume will go? It goes in the capacitance vessels, they dilate under the effect of progesterone. Under the effect of the progesterone, the capacitance vessels dilate and they accommodate increased blood volume. So they accommodate increased blood volume because the capacitance vessels, the peripheral blood vessels, they dilate due to the effect of progesterone. So peripheral vascular resistance decreases. Central venous pressure remains constant, peripheral vascular resistance decreases, and the formula cardiac output is equals to heart rate into stroke volume. Everything increase. Okay, because we have studied that peripheral vascular resistance decreases, that is why the uh, mother has syncopal attacks in pregnancy. Mother has syncopal attacks in pregnancy because the peripheral vascular resistance decreases in pregnancy. When the pregnancy is full term, when the pregnancy is full term, then when the mother is lying in supine position, see here in the diagram, see here in the diagram, mother is lying with full term pregnancy. So this full term fetus compresses the inferior vena cava. It compresses the inferior vena cava and it leads to hypotension. And this thing is known as supine hypotension syndrome. At full term, when the patient mother lies down, not as such, only when the mother lies down, their fetus compresses is the inferior vena cava, and because on compression of inferior vena cava there is decrease in return to the heart, so the mother gets syncopal attack on lying down. So it is known as supine hypotension syndrome. Okay, so there are two types of syncopal attacks in mother. One is at every time due to the decreased peripheral resistance, and one is at the full term when mother lies down. Now when they ask you this supine hypotension syndrome, what they write down in option, one option they give superior vena cava syndrome, and one option they give supine hypotension syndrome. So in the exam, out of stress, we might mark their superior vena cava syndrome. Student, superior vena cava is in the brain. Superior vena cava is in the brain. Fetus cannot compress superior vena cava. So the answer is supine hypotension syndrome. Okay, please mark this thing. It is supine hypotension syndrome. So today class is only this much. Uh, if there is any query, please write down in the chat box. We will continue the remaining class tomorrow. Please write down in the chat box if there is any query. Okay. Thank you. If it's clear. Thank you, Dr. Isra. Thank you, Dr. Isaac. Thank you, Dr. Zabi Kausar. Thank you, Dr. Mohit Ruhela. Thank you for joining me. See you soon tomorrow at 4:30 p.m. tomorrow again 4:30 to 6:30. Thank you.